Thank you so much, everyone, for being here. Today we are joined by, you can see, many wonderful people, all here on behalf of the Center for Rural Health, the Arizona Center for Rural Health. And our main headliner, if you will, is Dr. Dan Derksen. He has a very long list of accolades, but to keep it a little bit succinct, he's the Associate Vice President for Rural Health Workforce Development Initiatives. He's the Director for the Arizona Center for Rural Health, the Senior Advisor for Arizona Area Health Education Centers Program, also a professor here in public health, medicine, and nursing. And today's topic is going to focus on Arizona's Rural Health Transformation Program funding opportunities. This is something that is new and exciting. We're going to hear all about that today. If you haven't come to any of the seminars in this series so far, we did 4 of them last semester, and we have another 4 for this semester. So once a month, the research office has planned the seminars. So today's is rural health, and then we have other ones upcoming March 18th, which will be, we'll have people from Pima County Health Department presenting. April 8th will be some of our new faculty that have joined the college as part of the School of Health Professions. And then on May 6th, we will have AI and digital health focused research. So please continue to join us and invite people to join as well. I'll start briefly with our land acknowledgement, and then we'll move right in. We respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And with that, I will hand it off to Dr. Derksen.
Great, thank you, everyone. Can you hear in the back okay? As we hand it off, people have various volumes of voices. Usually I can project pretty far, but others may not. So we'll use the microphone. And as we introduce folks from the Center for Rural Health, they'll tell us a little bit about the program that they focus on in the center. My name is Dan Derksen. I'm a family physician by training, graduated from medical school way back in 1984, but came back to University of Arizona almost 14 years ago now. So as we mentioned before, I direct the Center for Rural Health, and we house a number of federally funded and state funded, now foundation funded programs, and we work very closely hand in glove with the Area Health Education Center program, the 6 regional centers, and the 10 rural health professions programs. So one of the aims of this was also so that you meet some of the folks in the areas that are in the Center for Rural Health. And then once we go through the brief introductions and programs, we'll go into the Rural Health Transformation Program, which I think is a pretty exciting opportunity for the state of Arizona. So Jill, and I'm gonna have folks come over because so folks can see you online and introduce yourself.
Hi, good afternoon. I'm Jill Bullock. I'm the Associate Director here at the Arizona Center for Rural Health. I primarily work on the Arizona Rural Hospital Flexibility Program, or we call it here in Arizona, the AZ Flex program. And the Medicare Rural Hospital Flexibility Program is designed to strengthen rural healthcare delivery systems by supporting critical access hospitals and encouraging the development of local and regional systems of care with cause. That's what we call critical access hospitals as hubs. And in Arizona, we call it AZ Flex. And it's a vehicle to help our 17 critical access hospitals here in Arizona to improve quality, strengthen their finance and operational performance, pursue population health initiatives, and integrate EMS services into rural systems of care. And Flex program funding supports provide support for vulnerable critical access hospitals in a challenging healthcare environment, particularly in these important areas of performance. So also under the Flex program, we have received funding for EMS, and we've been working with the Arizona Emergency Medicine Research Center, and they are working towards EMS workforce to give them some grants to build up the workforce for EMS. Thank you.
Great, and I put up a slide. This is the slide where Shippard only allowed us one slide for the presentation we give to the president tomorrow. So this is one that doesn't summarize all the initiatives that we house in the center, but the one you just heard about is a 5-year competing continuation. I think we're in year 2 of that, year 2 of 5, and then we're in year 5 of 5 of the State Office of Rural Health Program, which is a state and federal funded and designated program. So very soon here, we'll be writing our 5-year competing continuation. And this allows me to introduce Jen Peters, who is the director, our program director for that program. Jen, come on over where you're in front of the camera there.
Sure. Good afternoon, everyone. It's great to see so many people here and be able to tell you a little bit about what we do at the Center for Rural Health. So as Dr. Derksen mentioned, my name is Jen Peters. I'm the program director, manager for the Arizona State Office of Rural Health Program. And that is, as noted up there, a federally and state designated official state office of rural health, which basically means we serve as a single point of contact and kind of a symbolic bridge between rural, tribal and underserved communities and the Federal Department of Health and Human Services. We've been established since 1990. So we've been operating, had this grant concurrently for 35 years. We are one of 10 university-based state offices of rural health in the country. Most of them are in health departments, but being university-based, we do have a lot of interesting options and abilities to partner and participate in research and evaluation. And we are funded through a 1-to-3 match, which means that one part of our funds comes from the federal government, and it's matched, every dollar is matched with $3 from the state of Arizona. So our main functions are to serve as an information clearinghouse, to provide technical assistance, and to coordinate activities and really support the development of networks or support existing networks in the state. So I'll just end with, if you want to think about what our program could do for you, you could think about connections, you could think about information and data, and you could think about assistance in program development. So, thank you.
Yeah. Just come on over. The camera's right there. So.
Hi, so I'm Bianca Santamaria. I work for the Overdose Data to Action Grant, where we focus on overdose prevention and harm reduction. I kind of oversee the operational portion of the grant, and we do a lot of trainings on overdose prevention, naloxone administration, as well as CDC prescribing guidelines. And I'll allow my colleagues to talk a little bit more about other things we do.
Rocio.
Good afternoon, everyone. My name is Rocio Torres, and I am a research professional at the center. And I support the Overdose Data to Action state in different capacities. Especially, I lead the program evaluation and also leading education for clinicians on the CDC prescribing guideline for pain management. I also lead the scoping review project with a multidisciplinary team. We are searching on opioid prescribing practices in the US and subsequent falls. And also with more colleagues, I work on the Geriatrics Workforce Enhancement Program, WEB. And my team and I facilitate connections with different critical access hospitals. And we engage in community meetings with different representatives in Benson, Cochise County. Thank you.
Just a word about, so the Overdose Data to Action is one of those grants. It's a federal grant, and only the state could apply for it, but then the state, through an interagency service agreements, have us do some of the work. The Geriatric Workforce Enhancement Program is through the Center on Aging. Mindy Fain's the lead on that, and we collaborate on this and other programs with different entities, but that's been a really important one because Arizona's got a very fast-growing aging population, people like me over age 65, and it's really important that we have programs that really address the workforce, but also the needs of an aging population. Raymond, next. I don't think Rocio needed a microphone.
Good afternoon, everyone. My name is Raymond Valenzuela. I also work on the Overdose Data to Action State Program, as well as the GWEP program. For the Overdose OD2A, I'm leading a team in developing an educational video for public health and public safety organizations to support overdose prevention.
Great. And Raymond also was our leader for the Navigator program. Certified navigators help people with eligibility, enrollment, and redetermination, not only for Medicaid, but also for marketplace coverage. The current administration cut that funding by 90%, so we are one of the folks who lost some funding around that. The effort still goes on, but it's very much diminished from where it was. Huge issue for our state as far as making sure people have access to affordable health coverage. Joyce, you're next.
Okay, I look there. Hi, everybody. I'm Joyce Hospodar, and my title here is Senior Advisor for Rural Programs. I have some history here and been here a long time. And some of the projects that have been mentioned, I do work on them, but I'm going to focus in on the Arizona Rural Recruitment and Retention Network. This is a program that is part of the National Rural Recruitment and Retention Network, or as it's known as the 3R Net. And so with this, what I do and manage for the state, along with the Arizona Alliance for Community Health Centers, and those are our FQHCs in the state, and also the health department for the J1 placements. So what I do under the 3R Net is I get promotion to get agencies to promote their openings in the rural areas. And then I see who's looking for jobs. And then I also get requests for people who want to, organizations who want to post. And we have to be very careful about who we put on there for the rural areas. So it's a very dynamic system. We've been involved, as Jen said, with being the State Office of Rural Health. We've had this program for years and it's very successful. It's open to all types of rural people looking for jobs. So thank you.
One of the challenges in our state is there's many parts of the state that are rural or very low population density, what's called frontier areas. And many of the clinics and hospitals and other health services organizations that provide services have vacancy rates, that approach 50 or 60%. So part of the Rural Health Transformation Program that I'll be talking about in a moment is really how do we develop, train, but also distribute a well-trained health workforce into the highest areas of need around the state. Melissa?
Hello, my name is Melissa Islas. I am the program manager for the Arizona Small Hospital Improvement Program, also known as AZ SHIP. It has been funded by HRSA since 2002. We fund 14 out of the 17 critical access hospitals in Arizona and provide funding for quality improvement. Also, this lovely map is right here in the front with calendars and our annual report if you wish to take one after. Thank you.
Yeah, Ann Garn, who's coming up, helps us with a lot of the graphics, including our annual report. In the middle of that is a racy centerfold with this map on it, with all the critical access hospitals and Indian Health Service, tribal operated sites, federally qualified health centers, rural health clinics. So a lot of federal acronyms, but this is really the critical strands of the safety net and a key component of the Rural Health Transformation Program in making sure that individuals in Arizona have access to high quality care, but also affordable care. So next up is Mariah.
Hello, everyone. So my name is Mariah Earhart, and I focus mainly on community outreach. So as you hear about all these amazing programs, as well as the others to come, I get to highlight those and others around the state. So two main ways that we do this is through our conference in June and February. So February's conference is the Policy Forum, largely focusing on policy efforts that impact rural and public health. And so unfortunately, as amazing as it sounds, and I know all of you want to attend, we are sold out, which is very exciting, but we do post all of the PowerPoints for that. So if you're interested, feel free to look on our website afterwards. And then in June 2nd and 3rd, we have our Rural Health Conference in Flagstaff, Arizona. So generally that's around 350 people 2 days to really network and learn about these initiatives going on in Arizona.
And do students have an opportunity to present there?
Yes, that is a great question. So if you didn't hear, do students have an opportunity to present there? We do allow students to both present regular presentations, so like PowerPoint breakout presentations, or poster presentations, and those tend to be really popular. So if you're interested, you can submit a presentation proposal right now. They're actually open.
Thank you, Mariah. Brenna? Oh, the trio.
Yes.
The trio. I'll get
Yes. Hi, everybody. My name is.
Can you stand over toward the camera there?
Yes. Okay. We'll switch places. All right. Hi, everybody. My name is Brenna Koch. I'm an assistant research professor here at the College of Public Health, working primarily with the Center for Rural Health. I'm going to talk about 3 projects very quickly. I'm going to talk about our workforce data initiatives, which I'm very lucky to work with Charles Drake and Susan Coates on. They are data architects. Charles manages our data warehouse and collecting and compiling all the public and publicly available data on health workforce so that we better understand the distribution of the healthcare workforce, particularly rural-urban disparities in workforce availability across the state. Susan leads on our data visualization. So we have some publicly available Power BI reports on our Center for Rural Health page that describe, again, that distribution of the workforce across the state. And she's our GIS specialist, helping to create the jazzy centerfold map that you see here in collaboration with Ann Garn in our design and communications team. So that's workforce data. I also have the privilege of working on the Arizona Rural Obstetrics Maternity Strategies grant with rural FQHCs and rural critical access hospitals that uses a network approach in order to improve the quality of maternal health care access in rural areas across the state. And then I also lead the College of Public Health Rural Health Professions program, which coordinates 4 service learning courses that gets public health students out into communities to learn more about what public health looks like out in the field. And I have one of my students here, so thank you. All right, that's us. I'll pass it to the next person.
Thank you.
Hi, I'm Patrick Wyman. I'm here, I fill 2 roles. I am a general purpose health economist, interacted with a lot of you here, and I work on projects all over health sciences. The second role is I am the director for population health at the Center for Biomedical Informatics and Biostatistics, or CB2. And in that role, I am the liaison between the university and state health agency. And so which means if any of you have any interest in using state data resources for projects, I am the one that you will talk to. That's it.
Thank you, Patrick. One of the things that's going to be important for the Rural Health Transformation Program, the Office of Economic Opportunity is a state agency that will oversee the portfolio of funding related to health workforce education and training. And they have envisioned an integrated data system. And one of those things we worked on a few years ago on the policy side was at the time of licensing and renewal of health professionals like physicians, nurses, physician assistants, and others. There's a survey done so that we can get a better sense of clinical full-time equivalent by area of practice. If you know, like I have an active license in the state of Arizona, but I don't see patients anymore. So I would be counted if you just looked at active clinical licenses as a full-time equivalent, but because I don't see patients, I'm not adding to the capacity of being able to see them. So what we tried to do is integrate some of that data through this health workforce database, and then now working with the state to integrate that into their integrated data system. So this will be really important as we track, did we make progress? This 167 million a year that we're going to get for the Rural Health Transformation Program, did that investment each year over the next 5 years make a difference in getting more licensed health professionals out to the areas that most need them in tribal, rural, and border areas? So next up is Mona.
Thanks, Dan. Hi, everyone.
Right.
Sorry, I forgot. Hi, everyone. Mona Aurora. I wear a couple different hats here on campus, but with the Center for Rural Health, I'm fortunate to
be working on continuing some projects that we actually started during the COVID pandemic. Many of you know this, we received a large grant, federal pass-through money to really address health disparities coming out of the pandemic. And while that grant has ended, we're continuing to maintain those relationships. Tidbit for everyone, we engaged over 400 partners across the state in rural small communities to really get the monies where they needed to go and to build some of those programs. So part of my role now is to continue some of that work through work I do in other kind of hats, for example, extreme heat, really calling attention to some of the health inequities that continue to stress our rural communities, but also trying to keep those community members and partners engaged through some of the other work that we do at the center. In addition to that, I also support Brenna and Jen with the Rural Health Professions Program, doing some of the data reporting and evaluation. And finally, I also teach one of the 4 service learning courses with Nate Lothrop. I'm going to have a flyer. I'll leave it up here if you're looking. Our last course, which is focused on climate and health in rural communities, is going to start right after spring break, and we still have room. And we're going to be going to Superior and Bisbee to really engage our students. So thank you very much.
Thank you, Mona. Ann?
Okay. Hello, everyone. My name is Ann Garn. I'm Manager of Marketing and Outreach for the Center for Rural Health. So I work with all of these programs to do strategic communications, as well as design support for reporting and other deliverables. So all these things out here you can grab on your way out. I had a little hand in making them beautiful.
Thank you, Ann. Pam? Now the money part. Oh.
Of course, there's a money part to this. My name is Pam Barnes. I am the finance lead for the Center for Rural Health. And I, like Ann, get to support all of these wonderful people and programs that we do. And I also work closely with sponsored projects to ensure compliance on all of our grants. And then I do a little dabbling with AZAHEC still in supporting them in anything extra that they need as they go through their processes too. Thank you.
Great. Let's give all the folks a big hand for So the folks you just met are resources not only around the state for our formal and informal relationships we have with a lot of the sites that are located on that map, but also an internal resource. We work very much across departments, across colleges, both north and south of the Great Gulf of Speedway there, main campus and North Campus. So they really do a terrific job. They're kind of seen as almost like Switzerland, you know, they'll work with anyone, and I'd take advantage of their expertise. What I wanted to switch to now is some of the things that, you know, on July 4th, the president signed into law what I prefer to call HR 1. I'm not fond of the One Big Beautiful Bill Act. OVA's okay, I guess, but HR 1 is about 870 pages. And how many people have read all 870 pages? I have. Of those 870 pages, there's 17 pages that are good. I'm going to focus on. Okay, so we'll start with the good stuff. And it's Title 7. You know, every big bill like this has multiple titles. Title 7, Section 71401 is about 17 pages. And this was a compromise provision because a whole bunch of those 870 pages is how we're going to go about cutting $1 trillion from state Medicaid programs. $34 billion over 10 years for Arizona alone in loss of federal dollars. This is $10 billion a year for 5 years. So it's a significant amount of money, but it in no way makes up for the loss that we're going to have in federal dollars down the road when new Medicaid provisions go into place in January of 2027, which is just around the corner. I'll talk about that in a moment. For those of you who take Leila Barraza's class or mine and maybe some others, there's two things maybe in civics that you need to understand about the federal budget. What you've been hearing about mostly is continuing resolutions around the discretionary side of the federal budget. So a lot of the programs we get funding from in grants like Health Resources Service Administration or National Institutes of Health or the Centers for Disease Control, other ones like that, substance abuse and mental health services grants. That's all discretionary side of the budget. Indian Health Service, discretionary side of the budget. The VA, discretionary side of the budget. So those are ones where we have to fight every year for budget things. And in some years, like this one, we're fighting continuing resolution to continuing resolution. On the mandatory side of the budget, this is the one that a lot of folks refer to as the third rail. Like if you've ever been in DC and you see where all the rats go to die along that rail that's electrified. The third rail in politics is if you mess with people's Social Security, you mess with their Medicare, that's a good way to be sent out in the next vote. So Medicaid, Medicare, Social Security, all in the mandatory side of the budget. The Real Health Transformation Program is on the mandatory side of the budget. So it's not vulnerable to the things going on with continuing resolutions right now. By the way, ICE, discretionary side of the budget, that's the one thing they have to negotiate out, or that part of the thing that's in that bundle of discretionary funding, including ICE, is vulnerable, and they're still negotiating that out. That'll expire toward the end of this month. So this provision is a fair amount of money. About half of it will be distributed evenly to states. So if you work out the math, it's $100 million a year for each state. That's going to be divided equally. The other up to $100 million a year or more is distributed on the basis of metrics that the Centers for Medicare and Medicaid Services decides on. Things like, what percent of your population is rural compared to the rural population in the United States or compared to other states. In our state, Governor Hobbs leads this effort. So she has designated the responsibility to her policy advisor, her health policy advisor. Megan Kramer is her name. She's a JD by training, a lawyer, very experienced in state politics, but also good about implementing new programs. And then Josue Macias is the person on loan basically from the state Medicaid program, the Arizona Healthcare Cost Containment System. So those two kind of led developing the response. They had a lot of stakeholder meetings around the state, including tribal stakeholder and listening sessions. And they put together the proposal. The Centers for Medicare and Medicaid Services put out a notice of funding opportunity in the fall. States had about 60 days to respond to that. They were limited to, I think, 60 pages in their narrative, and they had to come up with a budget. And CMS encouraged them, each state, to put in a budget of $200 million. And then by the end of December is when CMS awarded them out. So Arizona was awarded, they put in for $200 million a year, as CMS has suggested to all the states. They got $167 million a year. So it's a substantial amount. We'd asked for $1 billion over 5 years. We got $835 million. It's still a lot. But comparing the total to other states, we're the sixth lowest of the states. And there's been some stories about this, we got shortchanged and all that. If you look at it from how much we got per rural resident, we're about 22nd, so kind of middle of the states. But still, there were other probably political factors that played into it. Our population is about 10.8% rural. And the United States overall is about 20%. So that's part of the reason we got less than some others. So now every state has to submit, or had to submit, to CMS the revised budget, their revised narrative, and get that into CMS by the end of January. Every state did that. CMS has now 30 days to either renegotiate something if they want to quibble about something a state put in, or approve it. So we'll know by the end probably of this month, maybe the first week of March, whether we have full approval. I think our proposal as a state was quite good. I think the way they distributed the amounts in the priority areas was very well thought out and written. So I suspect they'll be approved. Once CMS approves it, then the governor has assigned 3 of their state agencies to oversee the distribution of funds based on the priority areas that they put into their 74-page narrative. So all these elements, the narrative that they submitted, and then the revised one, and the budget are on our Center for Rural Health website. And these slides will be made available. So I encourage you, if you're really interested in stuff, it's actually very well written. I mean, especially the 5 pages I wrote, but you know, the other stuff was good too. No, but there was a lot of really thoughtful ideas. The 17 pages in HR1 that deal with the Rural Health Transformation Project barely said a word, if they said any word, about tribal health. And in our state, you know, we're at 22 federally recognized tribes, 27% of our state land area is tribal. This is a big issue. And these are places that I mentioned have 50 to 60% vacancy rates for across the board as far as health professions. So we, as a state, put in some issues related to how would we address some of those workforce shortages, how would we improve access to care, how do we make sure that care is affordable when people go in and get seen. Once they get the approval, then the 3 state agencies responsible, Office of Economic Opportunity around health workforce, the state's Medicaid program around a pretty big portfolio of issues, and then Arizona Department of Health Services will distribute out through competitive notice of funding opportunities, requests for proposals. And depending on the complexity of those proposals, folks will have 30 to 90 days to respond and get their proposal in. So, you know, I always like the aphorism that luck favors the prepared. So we've been having a series of meetings with interested faculty and staff, and a number of folks here have participated in some of them, or not more than one of them. So we want to be prepared, and we're preparing our Office of Research and Partnerships, or sponsored projects pre-award, because the cap federally by this law is 10% indirect costs. You know, we get 53% indirect costs for our National Institutes of Health. So this is 10% cap. So the state thinks they can do it through their state agency for 3% of that, and then the successful sub-awardees will get the balance, 7%. So we have to get special dispensation all the way up to the president to allow us to charge less than the negotiated rate we have for these federal opportunities and state opportunities. So this is the breakdown. I know this is a lot of numbers. You know, it's like Chevy Chase used to say, I was told there would be no math. Well, there's a little bit of math here, so you have to pay attention. A big one is really around health workforce and education, which is good news for those of us that work in health professions, education, and training. About 47 million a year for 5 years. So it's a substantial investment in health workforce. And these are the areas, the bulk of that is really around education and training expansion. And what the state is most interested in when you get into the details of their proposal is really training that occurs in areas of need. So rural, tribal, border. They don't want to just see a whole bunch of money going to the usual places, Phoenix and Tucson. You know, I mean, we're happy to get state funding and federal funding here. We have $1 billion a year research portfolio here in Tucson, but the state is really prioritizing, and the Centers for Medicare and Medicaid Services are prioritizing the type of stuff I think we lead the country in, which is community-based experiential training. You heard about a little bit of this in their Rural Health Professions program stuff. We also have AHEC scholars. Some of you might be AHEC scholars. These are the types of things they want to see, is training that really occurs and is centralized in rural, tribal, and border areas. And that's really important. We know from the data, when you do a significant portion of the training in those areas, people are much likely, when they finish that education, they get that prized acronym behind their name, that they go into practice in those areas. So this is a big area of focus. And then you can see some of the other breakdown in that priority 1. Priority 2 is kind of a smaller portfolio as far as total funding. I thought they should have put a lot more in maternal health. If you look at some of our maternal and infant mortality in the state, you know, the United States as a whole does worse than 37 developed countries. We don't do very well as a country. And then Arizona's worse. And then if you get outside of Pima County and Maricopa County, it's pretty alarming. It's worse than many third world countries. So this is a fixable issue. To me, this is something that with a significant recurring appropriation or funding, we could really do a lot to make a big difference in this. We started some of this by starting a new midwife program. Hadn't been one in Arizona for more than a decade. Erin McMahon leads that. We're hopefully, we just went through the accreditation steps and hopefully start admitting the first class of physician assistant students this fall. I think they interviewed over 1,000 applicants for 50 positions. High need, kind of area, nurse practitioners, others. This proposal really talks about, we've done some things around physician workforce, we've done many things around nursing workforce, maybe certainly not enough, but they really want to look at advanced practice health professionals. So that includes PA, PT, occupational therapy, community health workers, medical assistants, things like that. They want to see more partnership between academic centers like here at the University of Arizona with things like community colleges, the public community colleges and others. So behavioral health, substance use disorder in states like ours that share a significant border with Mexico, this is an issue where, fentanyl gets into things, people don't know it. We have overdose, we have deaths related to that, much higher than other states. So behavioral health, if you look at health professions shortages, this is the largest along with dental that we have. So we have a lot of work to do. The state Medicaid program is going to oversee the distribution of funding related to behavioral health and substance use disorder. And then Arizona Department of Health Services will do the maternal health and the chronic disease one. These are ones I have less expertise in, so my comments will be briefer, but things around what can we do to expand the reach and really use technology in a new way. This is something I think those of you going through now, the transformation of what's going to happen with artificial intelligence. Just when I talk to physician colleagues that are in places that have these incredible ambient artificial intelligence that captures at the time of the visit and documents it right in the electronic health record. Electronic health record was supposed to save us so much time and money and all that kind of stuff. It was like, it seemed to create more because people stayed late into the evening finishing their charts. Well, the ambient AI seems to be delivering on that promise, at least the ones that are, better. So there's a lot we could do around that. Rural hospitals operate, the critical access hospitals, the 25 beds or less, 35 miles or more from another facility. They operate in 1% and 2% margins. So, if they make a mistake in investing a bunch in an electronic health record or ambient artificial intelligence, it's hard to recoup that loss. So part of this effort in these two priorities, 3 and 4, is really, can we get an economy of scale? Some technical assistance, shared service, because you get an economy of scale. You might be one critical access hospital, like Cobra Valley is their own entity. They have about 6 rural health clinics in the kind of copper corridor cities around central Arizona. But they may need some help. If they pool in with the 16 other critical access hospitals for some of these things, they could really, expand their ability to deliver better care and take advantage of some of the new technology, electronic health record upgrades, data sharing, medical and diagnostic equipment. So these are ones that will all be administered through the state Medicaid program. And I want to talk about this because this is the scary part for me of the first thing is what didn't happen when HR 1 was passed is they didn't extend the advanced premium tax credits that made Affordable Care Act, Obamacare insurance more affordable. Last year in Arizona alone, we had a record 423,000 people sign up for Affordable Care Act marketplace plans. This premiums that made that very affordable for a lot of Arizonans and across the country expired in December. And there hasn't been any action in the current administration or the current majority in the House and the Senate to extend those advanced premium tax credits. This is what caused that first kind of prolonged government shutdown on the discretionary side of the budget a couple months ago. They wanted to see those tax credits extended. These are tax credits for people in the lowest end of the income bracket. So when you look at HR 1 and you look at who benefited the most, it was really people in the top 1% of the income. The average benefit to people in the top 1%. So to qualify to be in the top 1% of income is you have to be around 650,000 a year. So that probably pretty much excludes most of us, I would say, all of us. Anyway, their average benefit of this tax cuts for them is 66,000 a year, which is 3 times the eligibility threshold for qualifying for Medicaid. So a lot of people have referred to this as reverse Robin Hood. You basically cut $1 trillion in funding to Medicaid across the country to create literally $1 trillion in tax benefit for the top 1% of income earners in the country. So this is why a lot of people are really upset about this kind of stuff. But already we're seeing in Arizona, compared to where we were in the Affordable Care Act marketplace, that we're 70,000 lower than we were. And as people see the premiums and have to pay them every month and decide, do I want to buy groceries? Do I want to pay my rent? Do I want to pay electricity bill? Versus do I continue my my premium costs right now, my out-of-pocket expenses? So we're going to see probably about 150,000 people currently on Affordable Care Act marketplace lose their coverage because they can't afford it over the next 12 months. And then the really bad stuff, this is the storm clouds kind of looming, start to happen in January 2027. So this, not inadvertently, is about a month after the midterm elections or so. So in November is the midterms. There's a lot of people on both sides of the aisle on Medicaid that depend on Medicaid for coverage. In Arizona, we're at about 1.8 million Arizonans who currently are on Medicaid. And what's going to happen starting in January 2027 is then instead of once a year having to update your data on eligibility and enrollment and redetermination, you have to do it twice a year, specifically designed to throw people who are eligible on the basis of income off of coverage. Does that really save money? It doesn't save money, especially if you didn't realize you have to go into clinic suddenly you're not covered anymore. You didn't update your data. The other part that happens in January is work requirements. So there's a lot of work our state Medicaid program has to do for its information technology system to put new data entry fields in around these work requirements, a lot of stuff. And they have a 20-year-old kind of legacy system. They're overhauling it. They're getting some help from a top-notch entity, Accenture, to overhaul that system. But we need a system that works well for public benefits, for eligibility, enrollment, and redetermination. So this is around Supplemental Nutrition Assistance Program. It's around Medicaid. It's around women, infants, and children. It's around other things as well. So these are some of the things looming, and the estimates by the Congressional Budget Office, the Kaiser Family Foundation, KFF, is that 250 to 400,000 Arizonans currently on Medicaid will lose coverage because of these new provisions that start in 2027. So if you're operating on a 1 or 2% margin and suddenly you lose 10 or 15% of the people who can pay for coverage because they have Medicaid, it's going to be very hard for our rural hospitals and clinics to stay open. So these are some of the estimates in case you want to do some primary source verification of the data, where it came from, how much we're going to lose. 34 billion is kind of the number in between 26 and 43 billion over the next 10 years. How many people are going to lose? There's estimates that KFF does, and they update this as they get new data each year. So these are pretty big losses. And who loses in this system? Well, the first thing is, of course, the current enrollees that lose coverage because they didn't update their phone number, or they moved, or they didn't do the work requirements as they're supposed to. But also the strands of the safety net, the 17 critical access hospitals in the state, the 54 rural health clinics, 26 health centers that operate, over 175 federally qualified health centers. In our area, 14 FQHCs are operated by El Rio, as an example. 16 Indian Health Service and 28 tribal operated sites. Those are the ones who really depend on the Medicaid and Medicare revenue. They serve a disproportionate share of those public payer patients. They also absorb, by law, they have to see people regardless of ability to pay. So as people lose coverage, they're going to have to shoulder a bigger burden of uncompensated care or charity care. So that's the end of it. Did I do okay? Okay, Pam was the timekeeper there, so. Do we have time for questions or we got to end?
Yeah, we just run a little bit. Let me.
Any questions that anyone has? Yes.
Daunting and moving picture that you portrayed in the coming years. So what are ways that we're gonna have to understand
Yeah, I'm trying to start with some positive things before we get totally depressed. But here's the thing I look at. Things could change in a heartbeat in November. You know, people won't get into office and the changes won't happen in the majority and things like that until January and beyond. But you can block and repeal a lot of the more obnoxious things that are in HR1 or the more obnoxious things that come through executive order and other things like that. So I'm optimistic on those things. I was fortunate when I did my health policy fellowship. It was right at the tail end of the second Bush administration where he talked about cutting billions and wasteful and bloated government programs into the lead up to the Obama administration, where suddenly the window of opportunity opened. Can we really get more people insured? Can we reduce the number of people who become bankrupt because of medical costs and things like that? So I'm hopeful for new windows of opportunity. And I think it's really important that we get involved. We take advantage of new investments like this through the Rural Health Transformation Program, and we leverage the programs and the relationships we have to really make sure that we start to train people in areas of need, and we recruit and prepare people from areas so that, you know, our health workforce better reflects the diversity of Arizona and better serves the population. So I'm optimistic about some of these things, but I also I do worry. Yes, is there some questions online?
No one has typed any in the chat yet, but I asked them to if they had any.
Well, we're almost right at the time. If anyone feels shy about asking a question in front of so many people, I'll stay around for a bit afterwards, and some of my colleagues from the Center for Rural Health, if you want to touch base with folks. So here's one. What's one thing we can do to lower healthcare costs while simultaneously increasing access? I think we have to somewhat focus on some of the issues that are within our grasp. So I think maternal health is one. With this kind of investment, $5 million is not enough, but with a similar investment through the state, I think we can make a huge difference. I think on substance use disorder and behavioral health, we've been actually had some pretty good news about some of the decreases. We're still way above where we should be. We have, you know, special challenges and opportunities located where we are in the country. But I think that there's enough data to show that when we do these types of interventions, they really do make a difference. I think on the workforce, we really have to change how we train and where we train. And I think this is where some of the promise of artificial intelligence and digital technology and other things, there's a risk-benefit ratio there, as we've seen with some of our kids in school and things like that. So we have to really pay attention to some of those things as we embrace new technologies to help expand the reach, whether it's health services or telehealth or technology, or it's how we train folks and where we train them. So I think those are some of the things. The data is pretty convincing that when we do these types of things, it's there, but we need to more rapidly disseminate those best practices to the highest areas of need and target our interventions there. So, all right. Well, thanks everyone. I'll stick around for a few minutes if you have any questions.
So if you can please give a little bit of feedback. I have a QR code up here for a short survey. I'll also send it out via email, but it's just a few questions to help us keep improving these seminars. Thank you all so much for being here.